Hello, everyone, and welcome to our educational lecture series from the Society for Perioperative Assessment and Quality Improvement, or SPAQI. My name is Dr. Marinee Khaligi. I'm a clinical associate professor of medicine at the University of Washington School of Medicine and the director of the Preoperative Medicine Clinic at the VA Puget Sound Healthcare System in Seattle. The goal of this educational series is to deliver short, high-yield videos around 5 to 10 minutes each that help healthcare professionals stay current on best practices in perioperative medicine. These videos are also meant to be practical and easy to use for teaching learners at all levels, whether you're working with medical students, residents, or other clinicians. Today's topic covers the preoperative assessment of functional capacity. This is one of the most fundamental skills in perioperative medicine, and being able to assess the functional capacity of your patients is essential for accurately assessing cardiac risk and guiding safe surgical care. In this video, we'll go over how to assess functional capacity. As you saw in the last video, assessing your patient's functional capacity is a major branch point in the AHA-ACC guideline for perioperative cardiovascular management for non-cardiac surgery, which traditionally has been measured using metabolic equivalence of tasks, or METs. A score of 4 or higher is considered as adequate functional capacity to proceed to surgery despite elevated calculated risk or presence of risk modifiers. The updated AHA-ACC guideline adds the Duke Activity Status Index, or DASI, as an alternate assessment tool to METs for estimating functional capacity. A patient scoring greater than 34 on the DASI is generally considered to have good functional capacity and can proceed to surgery. Let's examine these functional assessment tools in more detail. Metabolic equivalence of tasks, or METs, are based on the concept of energy consumption associated with different activities. One MET is the amount of energy consumed by a person while at rest, also known as resting metabolic rate. And it is defined as 3.5 milliliters of oxygen consumption per kilogram of body weight per minute. Using METs allows us to compare the energy costs of different activities relative to the resting metabolic rate. The Compendium of Physical Activities is a standardized reference list that assigns MET values to various physical activities, from household tasks and leisure activities to sports, and can be used to assess energy expenditure and functional capacity in different patient populations, including older adults, as shown in this chart adapted for senior-friendly activities. Energy expenditure for light exercise, such as light gardening and light household chores, is less than 3 METs, whereas moderate activities like weeding, walking at 3 to 4 miles per hour, carrying a light load while walking, or walking up an incline exceeds 4 METs. Traditionally, the ability to climb a flight of stairs or walk uphill without cardiopulmonary limitations has been used to determine preoperative fitness. The Duke Activity Status Index, or DASI, is a 12-question self-assessment tool originally used to evaluate the functional capacity of patients with cardiovascular disease, which was found to be of independent and incremental prognostic value for predicting significant angiographic coronary artery disease and long-term adverse clinical events in stable patients with cardiac disease. It also predicts mortality in stable patients with heart failure. The DASI score ranges from 0 to 58.2. Of note, the MD-Calc version of the DASI gives a METS equivalent for the raw score, which has not been validated and should not be used for clinical decision-making. In 2018, the Measurement of Exercise Tolerance Before Surgery, or METS study, set out to examine the validity of the DASI as a tool for assessing functional capacity and predicting risk in surgical patients. This was a multi-center international prospective cohort study of 1,400 adult patients with at least one cardiovascular risk factor who were to undergo non-cardiac surgery. Providers assessed the participants' functional capacity and categorized them into poor, moderate, or good functional capacity based on MET cutoffs of less than 4, 4 to 10, or greater than 10, respectively. Additionally, participants completed the DASI questionnaire and underwent cardiopulmonary exercise testing, which is considered the gold standard for determining a patient's functional capacity using METs. Postoperatively, daily EKGs, troponins, and creatinins were obtained for 3 days or until hospital discharge. The primary outcome of death or myocardial infarction within 30 days postoperatively was observed in 2% of the population. While the DASI score was associated with predicting the primary outcome, subjective assessment had less than 20% sensitivity for identifying patients with poor functional capacity, defined as the inability to attain 4 METs during cardiopulmonary exercise testing. A follow-up 2020 nested study found a non-linear association between the DASI score and postoperative MI or death within 30 days, which allowed for the integration of DASI scores into preoperative cardiac risk assessment. In this study, a preoperative DASI score threshold of 34, which correlates with about 5 METs on CPET, improved the identification of patients at risk for cardiac complications after major elective non-cardiac surgery. Patients with self-reported DASI scores of less than 34 experienced greater risks for 30-day postoperative death or MI, which is why this cutoff was included in the updated ACC/AHA guideline to determine the need for further cardiac risk stratification or optimization before elective surgery. As you can see, the odds of 30-day postoperative death or MI is about 50% higher in a patient with a DASI score of 25 compared to a patient with a score of 34 or higher. A post hoc comparison of DASI scores with subjective assessments revealed that only 15% of individuals with lower DASI scores than 34 were subjectively assessed as having poor functional capacity by providers, which is consistent with the original MET study finding of low sensitivity of subjective assessments in identifying patients with poor functional capacity. In summary, accurate assessment of functional capacity is vital to perioperative risk stratification. A MET score of less than 4 or a DASI score of 34 or lower significantly increases the risk of postoperative cardiovascular complications. And based on the MET study findings, the Duke Activity Status Index provides a more accurate and reliable method for assessing preoperative functional capacity compared to subjective provider assessments of METs. Therefore, integrating DASI into preoperative evaluations is strongly recommended to improve the identification of patients with poor functional capacity and enhance overall perioperative management and outcomes. This presentation provided an overview of the preoperative assessment of functional capacity. In our upcoming videos, we'll dive deeper into more important topics, including when and how to decide on further cardiac testing, practical ways to apply cardiac biomarkers in your clinical practice, and understanding myocardial injury after non-cardiac surgery and the role of postoperative troponin monitoring. Thank you very much for watching this video in our perioperative medicine series. If you find this overview helpful, please like and subscribe so you don't miss the upcoming videos where we'll explore more topics in depth. Additionally, we encourage you to share any questions or topics you would like us to cover in the comments below. Our goal is to ensure this series is as useful and relevant to you as possible. See you next time.